Hello everyone, myself Dr. Parth, and today I am going to teach you a very important topic from female genital tract, that is endometrial hyperplasia and endometrial carcinoma. This particular topic is very important exam point of view as well as in the medical entrance test. So first of all, let's begin with uterus basic anatomy, its part and histology. Then you can understand the hyperplasia and carcinoma in the detail. So what is uterus? It is one of the female genital tract organ, right? Which serves a very important role in a pregnancy, right? And it's a pear-shaped muscular organ. It is a muscular organ and located in the pelvic cavity. As we can see, the uterus is having three anatomical parts: fundus, then body of the uterus. This is the body, and lower portion is cervix. Now the cervix and body of the uterus connected by a isthmus, right? So this is the basic anatomy, and that is, and cervix ends in a vagina. So that is the basic anatomical parts of uterus. What is normal uterine histology? So if we talk about the histology of the uterus, then uterus is divided into three layers from outer to inner. The outer layer is serosa, which is known as a perimetrium. Middle layer is made up of smooth muscle, that is known as a myometrium, right? It is made up of smooth muscles. And as we know, the inner lining of the uterus is known as a endometrial lining, that is known as a endometrium, which is lined by columnar epithelium. So we have a endometrium, myometrium and perimetrium from inner to outer. All right. Now, among that all three parts, today we are going to discuss about the endometrial carcinoma. So we will focus on the histology of uterine endometrium. So endometrial lining is by columnar epithelium that will rest on stromal connective tissue. And you know, the superficial portion is known as a stratum functionalis, while the deep layer is stratum basalis. Ovary produces, ovary is another female genital tract organ, right? This is the ovary. This ovary will secrete a variety of the hormones, particularly estrogen and the progesterone. And under the effect of estrogen, endometrium undergoes proliferative change, while under the effect of progesterone, endometrium undergoes secretory change. So endometrium undergo characteristically morphological changes during the menstrual cycle due to sex hormone produced by the ovary. So here the morphological changes means proliferative phase and secretory phase. So normal menstrual cycle, as we know, begin with the shading of upper half to two-thirds of the endometrium during menses. So female having 3 to 7 days of the menses period, during which the upper portion of the endometrium will shed out if pregnancy doesn't occur. And then there is a beginning of proliferative phase for the first 14 days, and after that there will be secretory phase under the effect of estrogen. So female having proliferative phase, secretory phase, menstruation, and again proliferative phase. This cycle is ongoing, right? And the cycle is of 28 days in a female, usually average, but it can vary from 28 to 40 days like that of. Alright. So first uterus is having the proliferative phase after once the menses is completed for the 3 to 5 days. You know, once the bleeding stop, for the 3 to 5 days female having menses where the bleeding is stopped, and after that there will be beginning of proliferative phase. So proliferative phase is under the effect of estrogen. And if we talk about the histology, we know that endometrium rests on the myometrium. This is the myometrial smooth muscle, right? So endometrium lined by the columnar epithelium, and it is made up of variety of endometrial glands. See, it is made up of many endometrial glands. So endometrium is having endometrial gland and endometrial stroma. In between the gland there is a presence of connective tissue stroma. So two main portion of endometrial histology is the endometrial gland and endometrial stroma. So during the proliferative phase, the first phase of endometrium, that is proliferative phase under the estrogen, where the uterus endometrium will proliferate. So the gland will be straight, tubular and evenly distributed, and they are lined by pseudostratified columnar epithelium. And as it is proliferative phase, there will be numerous lots of normal mitosis. Mitosis is a marker of proliferation, right? So mitosis will be more. But if we talk about the stroma in a proliferative phase, then it is very compact. There is a compact arrangement of endometrial stroma, which is a spindle shape with very scant cytoplasm. And spiral arteries are very narrow and inconspicuous because mens is just over, right? This is proliferative phase. So spiral artery narrow and very inconspicuous. So this is about the endometrial gland and stroma in proliferative phase, right? So see, this is the proliferative phase. The glands are tubular, round, right? And stroma is very compact, spindle shape. This is the stroma. It is very compact, spindle shape with very scant cytoplasm, right? So it's a proliferative phase. Now, what will happen in a secretory phase? The proliferative phase is for the first 14 days, usually 1 to 14 days, right, under the effect of estrogen. Then, after the 14 days of menstruation cycle is over, there will be beginning of secretory phase of endometrium, which is under the effect of progesterone hormone. So, in the secretory phase, the secretion will begin. That's why the name is secretory phase, and the effect is under progesterone. So secretion first begin below the nucleus. So there will be first in the endometrial gland, the first sign of secretory phase is subnuclear vacuoles, right? So lining cells will develop abundant glycogen-rich subnuclear vacuoles because of beginning of the secretion. And because of the secretion, the glands will be enlarged, dilated, and sometimes coiled. As the secretion increases within the gland, it will push the nucleus, and so that ultimately secretion will discharge into the lumen of the glands. And because of that, glands will be dilated, tortuous, with inner side serration. And that's why this appearance is given the name sawtooth appearance. So see, this is the sawtooth appearance, inward folding, and that's only because increased secretion. What about the stroma? So endometrial stroma in a secretory phase will be very loose. There will be loose stroma. Stroma will be enlarged, and the cells are characteristically large round vesicular nucleus with abundant eosinophilic cytoplasm. So this is known as a pre-decidual change, right? This is the precursor of the decidual cells seen in a pregnancy, right? It is similar morphology like that of decidual cells seen in the pregnancy, right? So uterus is going to be ready for the conception. That's why there will be such type of appearance, right? And if conception doesn't occur, then spiral arteriole will collapse and there will be disintegration of the stratum functionalis, and so the blood will escape into the stroma and there will be beginning of the menstrual shedding, that is known as a menstruation, that will last for 3 to 7 days, right? So in this way, whole the cycle will get completed. All right. So identify the uterine histology herewith in this 4 diagram. This is a diagram from the Robbins book. So this gland is classically very round, tubular, lined by columnar epithelium. There is no secretion. So this is a proliferative phase of endometrium. And you can see that stroma is very compact. And it is made up of spindle cell which carries with very scant cytoplasm. So this is proliferative phase. Now what will happen in secretory phase? The secretion will begin. So secretion will begin from below the nucleus. So here you can see a subnuclear vacuoles within the gland. And you can see that glands is enlarged because of secretion. And the subnuclear vacuoles will gradually, as the secretion is increased, these vacuoles will gradually going into the lumen. The secretion will go into the lumen, so lumen can have a secretion. You can see a secretion within the gland. So in a secretory phase, the secretion is seen, and because of that, sawtooth appearance of the endometrial gland can be seen. And if you observe carefully, look at the stroma. Here the proliferative phase, the stroma is very compact, no cytoplasm. But here you can clearly see that cells is having very abundant cytoplasm and eosinophilic cytoplasm. The cytoplasm is very eosinophilic. So that is similar to like that of decidual change seen in the pregnancy, right? So this is the secretory phase, right? So you need to write down the endometrial gland and stroma histology in case of an proliferative and secretory phase. So the changes will occur in two substances. That one is endometrial gland and another one is stroma. All right. Now what is this? This is the menstrual phase of the endometrium. Why it is menstruation phase? Because you can clearly see that the blood is seen in the myometrium and the glands are disintegrated. So this is a menstruation that is of 3 to 5 days in a female. So these are the characteristic morphological changes seen in the uterus under the effect of estrogen and progesterone. So that's all about the normal anatomy and histology of the endometrium. Now you are ready to understand the endometrial hyperplasia and carcinoma. All right. So first we will begin with endometrial hyperplasia. What is the meaning of hyperplasia? Hyperplasia means increase in the number. So here there will be increase in the number of gland. So there will be increased endometrial glands to stroma ratio. Endometrial gland will be increased. That's why it is given the name endometrial hyperplasia. So obviously because of increased gland, there will be increased thickness of endometrium. That is due to proliferation of the endometrial glands. And it will present as an abnormal uterine bleeding. The female patient will complain of abnormal uterine bleeding, excessive bleeding because of hyperplasia. And as we know, hyperplasia is a fertile soil for the development of cancer cells. So in the background of endometrial hyperplasia, endometrial carcinoma can arise. So it is a precursor lesion for the development of endometrial carcinoma. What is the etiology? Why endometrial glands are increased? Why there is hyperplasia? So obviously it's because of proliferation. So proliferation is under the effect of estrogen. So the etiology is increased estrogen that lead to endometrial hyperplasia. The most common etiology is obesity, in which there will be more peripheral conversion of androstenedione to the estrone by the enzyme aromatase that is secreted by the fat cell. Polycystic ovarian disease, in which there is a multiple cyst in the ovary and there will be more estrogen and patient will have diabetes as well. Granulosa cell tumor of ovary. In the ovary, if granulosa cell tumor occurs, then it is hormonally active tumor and so there will be more estrogen secretion. If female is taking exogenous estrogen therapy, especially for the contraception, then there will be chance of hyperplasia. And obviously, one important reason is mutation of tumor suppressor gene, that is PTEN mutation. We will see the role of PTEN mutation in a carcinoma later on. All right. In the 2014, World Health Organization divided the endometrial hyperplasia into the two groups. One is endometrial hyperplasia without atypia, and another one is endometrial hyperplasia with atypia, that is known as atypical endometrial hyperplasia. Another name is endometrioid intraepithelial neoplasia. Why intraepithelial neoplasia? Because the stroma is not invaded, right? It is a precursor lesion for the development of carcinoma. So hyperplasia could be without atypia or with atypia. Now what is atypia? As we know, atypia is a loss of differentiation. It is one of the important features of malignancy. If your concept is not clear about the atypia or anaplasia, then you can see my video on nomenclature of tumor. So atypia is a sign of malignancy, loss of differentiation, right? All right. So first, endometrial hyperplasia without atypia. Obviously here the atypia is not present. Atypia means loss of differentiation, that is anaplasia. Which are the features of anaplasia? Which are the features of malignancy? High NC ratio, hyperchromatism, prominent nucleoli, loss of basal polarity, abnormal mitosis, etc. So that atypical feature is not present. It is simple or complex increase in the number of endometrial gland, increase gland to stroma ratio. That's it. No atypia is present. There will be back-to-back arrangement of gland, obviously because of proliferation, right? Intervening stroma is clearly seen, and it rarely progresses to adenocarcinoma. Adenocarcinoma means gland-forming tumor, endometrial carcinoma. So it's very rare that from this category adenocarcinoma develop. Malignancy chances are only 1 to 3%. It may undergo cystic atrophy when estrogen is withdrawn. Alright, so that's a straightforward, right, without atypia. But if in a endometrial hyperplasia, if there is an increase in the endometrial gland with nuclear atypia, which are the atypical features? High NC ratio, high nuclear to cytoplasmic ratio. Pleomorphism means variation in the size and shape of the cell, right? Vesicular chromatin, open chromatin with prominent nucleoli, right? Abnormal mitosis. So these are the atypical features. So if they are present, it is a category of endometrial intraepithelial neoplasia. Here the proliferating glands are very complex and the glands are arranged back to back, very crowded, branching of gland with loss of basal polarity. It mimic like that of endometrioid cancer. The only differentiating point is that stroma is not infiltrated in this category. Alright, so this is the endometrial hyperplasia without atypia. See, back-to-back arrangement of gland is seen, right? But if you see, then the atypia is not present. See, nucleus are the basal polarity is very well maintained. There is no high nuclear to cytoplasmic ratio. There is no variation in the size of the nucleus, right? Size of the seed, size and shape of the cell. So atypia is not present. This is without atypia. But if you look on the right hand side, then there is increased stratification. You see, this is the stratification, papillary infolding. So there is an increased stratification. There will be atypia. See, there is very high NC ratio. If you compare on the left side, the nucleus is very hyperchromatic, very dark blue colored stain, very hyperchromatic, right? And back-to-back arrangement of glands. So this is atypical features. So it is clearly seen in this diagram, right? So this is the endometrial hyperplasia with atypia. All right. Again, the same diagram. This is the without atypia, but here you can see a endometrial hyperplasia with atypia. This is without atypia, but here you can see atypical feature. See here, prominent nucleoli as well can be seen. This arrowed structure, you can see a prominent nucleoli within the nucleus, right? High NC ratio. You can't see a stroma. See, stroma is very scanty, very complex in nature. So this is endometrial hyperplasia with atypia. All right. So that's all about the endometrial hyperplasia. Simply, we can have endometrial hyperplasia without atypia or with atypia. So from which category there is a more chance of endometrial carcinoma development? Any guess? So obviously, the chances are more when the atypia is present. So if patient presented with atypical endometrial hyperplasia, then patient needs to be put on follow-up, because with the time from this category, with atypia category, the endometrial carcinoma can arise, right? All right. So now we will talk about our second topic, that is endometrial carcinoma. I hope that your fundamental is clear about carcinoma and the sarcoma. What is carcinoma? Carcinoma means malignant epithelial tumor. Any malignant tumor arises from the epithelium, that is known as carcinoma. And any malignant tumor arises from the mesenchymal tissue or the malignant tumor of mesenchymal tissue, like that of blood vessel, fibrous tissue, muscles, like that of known as a sarcoma. So if from the endometrial gland tumor is arise, then it is known as endometrial carcinoma. If tumor arises from the endometrial stroma, then it is known as a endometrial sarcoma. And if there is a presence of both malignant tumor of endometrial gland as well as malignant tumor of sarcoma, then it is known as carcinosarcoma. Today we will discuss only on the carcinoma of the endometrium, that is malignant epithelial tumor of glands, endometrial glands. You won't believe, guys, it is one of the most common pelvic invasive cancer of female genital tract. Age group is postmenopausal. The main age is postmenopausal, means after 45 years. And clinical presentation is abnormal uterine bleeding, which is a main characteristic feature. For that, the lady will undergo ultrasonography examination, right, pelvic examination, and ultimately growth revealed in the endometrium. So in that case, biopsy is taken and the diagnosis is done by histopathological examination. According to the clinicopathological and molecular features, traditionally it is divided into two groups, that is type 1 and type 2 endometrial carcinoma. Type 1 is endometrioid while type 2 is serous type of carcinoma. Now why to differentiate these two categories? Because the prognosis is different. Prognosis is very poor in type 2 while it is very good in type 1, right? So that's why we need to differentiate. Prognosis is different, treatment is also different. That's why the differentiation is necessary. All right. See, this is the new four molecular type of endometrial carcinoma, in which the endometrial carcinoma divided into four categories. One is Paul ultramutated tumor, then microsatellite instability tumor, that is hypermutated, then microsatellite stable where the tumor copy where there is a copy number is low, right? Tumor copy number is low. It's a microsatellite stable tumor, and fourth category is serous like tumor where the copy number is very high. We won't go in a detail of this new four category. I will take separate lecture on that. But today, just understand that carcinoma endometrium divided into two category, type 1 and 2. So first, we will begin with type 1 endometrioid carcinoma, which is very common, most common. More than 80% endometrial carcinoma is type 1 category. Why endometrioid name is given? Because morphologically there will be endometrial glands. There will be a well differentiated tumor, and there will be proliferation of the endometrial gland. So morphology is similar to like that of endometrial gland, and it is arising from endometrial hyperplasia with atypia mainly, right? Precursor lesion is endometrial hyperplasia. Morphology is similar to endometrial gland, and that's why the name given is endometrioid carcinoma. Obviously, as it is carcinoma, anaplastic feature is present, that is high NC ratio, hyperchromatism, prominent nucleoli like that of. But morphologically, it mimic like that of endometrial glands, arise from the endometrial hyperplasia. That's why it's an endometrioid carcinoma. Etiology is seen: increased estrogen, obesity, diabetes, hypertension, and ovulatory cycle, unopposed estrogen, tamoxifen therapy, and polycystic ovarian disease. So, because of increased estrogen, hyperplasia, and ultimately carcinoma. All right. Which molecular change that is commonly seen in case of this cancer? So common mutation observed are this one, right? Because of this mutation, ultimately there will be increased signaling through the PI3K-AKT pathway. This pathway is involved in a cell proliferation. PI3K-AKT pathway. And PTEN is a very important tumor suppressor gene for this pathway. If it is mutated, right, then this pathway is constantly getting activated. Mutation in PI3CA or KRAS mutation also could be responsible. Loss of function mutation in P53 and AIRD1A also could be responsible for activation of this pathway, right? So P10 is a very important tumor suppressor gene for this pathway. It is a negative regulator. If it is mutated, then this pathway is constantly activated, PI3-AKT pathway. And if this pathway is constantly activated, ultimately via mTOR, it will lead to cell growth, cell proliferation, cell survival, like that. So constant cell proliferation is seen if the P10 is mutated. And obviously because of KRAS and AIR1D1A mutation as well, this pathway is activated. All right. What will be the morphology? Suppose you have done the pelvic examination, and if you observe by naked eye, then grossly, a gross appearance like this one. One type is infiltrative. Grossly it can present as a diffuse tumor that involve endometrial surface. See, this is the infiltrative diffuse tumor. But sometimes it can present as a polypoidal tumor, fungating growth into the lumen. So these two type of presentation can be seen: infiltrative or polypoidal, fungating. Obviously, as it is malignancy, we know that grossly there will be presence of necrosis and hemorrhage. Necrosis and hemorrhage, if seen grossly by naked eye in any tumor, then it could be a malignant tumor. So that is a gross appearance. What will be the microscopic morphology? So as we have discussed, there will be feature of anaplasia as it is malignancy. So there will be high NC ratio, abundant mitosis, prominent nucleoli, and pleomorphisms, mitosis, tumor giant cell, all can be seen. Loss of basal polarity. And as it is the endometrioid carcinoma, arise from the endometrial hyperplasia, glandular pattern is seen. Right? The pattern is glandular. See, there is a glandular pattern. So gland forming malignant tumor, that is adenocarcinoma. So endometrioid type 1 endometrial carcinoma is an endometrioid type of carcinoma where glandular pattern is seen. Alright. What is the grading of the tumor according to the glandular differentiation? So grade 1, 2 and 3. 1 is well differentiated, 2 moderate and 3 is poorly differentiated. Alright. So grade 1 tumor is well differentiated means there will be easily recognizable glandular pattern. So mainly glands are seen, right? More than 70 to 90% of the tumor component is made up of gland. So that is a grade 1. Means the differentiation is not lost. And once the differentiation is lost, it is poorly differentiated tumor, which is a highly anaplastic tumor, and the prognosis is poor in a poorly differentiated tumor, right? What will be the feature in the moderately differentiated tumor? So here mixed component is seen, well formed gland as well as solid seat of the malignant cell. Why solid seat is keep on increasing as the grading is increased? Because there will be epithelial mesenchymal transition and there will be increased invasiveness of the stromal component. So if the solid seat and the glands both are seen, then it is grade 2. And if more than 50% solid seat is present, glandular pattern is less than 50%, then it is poorly differentiated tumor. So here you can see that this is the gross appearance with necrosis and hemorrhage, fungating growth. It is endometrial carcinoma. This is grade 1. Mainly glands are seen. You can see that this is the endometrial carcinoma grade 1. It's very well differentiated. But as the grade increases, there is a more anaplastic feature. There will be more high NC ratio, more prominent nucleoli. There will be loss of polarity, more mitosis, and obviously there will be more solid cell. Here you can see that glandular pattern is not maintained. So it is a grade 3 poorly differentiated tumor. Alright. So that was all about the type 1 endometrioid carcinoma. Now type 2 serous carcinoma. Now here, why the name serous is given? Because there will be secretion seen in this category, and it is not arise in the background of endometrial hyperplasia. It arise in the background of endometrial atrophy. Understand? It's arise from the endometrial atrophy. So it is usually seen after the age of 55 years. And irrespective of the morphology, it's very poorly differentiated tumor, grade 3 tumor, very poor prognosis. Morphology is similar to the serous adenocarcinoma of the ovary. Obviously, it is adenocarcinoma means gland forming tumor, right? The least common histological type could be carcinosarcoma or clear cell adenocarcinoma. Sometimes clearing in the cytoplasm can be seen. Molecular changes. What is the molecular changes seen in the serous carcinoma? So the main molecular changes is P53, PIK3CA mutation, FBXW7, triple P2R1A mutation, and BRCA12 mutation. So mutation are different as compared to type 1, right? So treatment is also different and the prognosis is also different. That is very poor in serous. Alright. Morphologically, the tumor is very bulky, invade the myometrium, and it arises from the precursor lesion of atrophied endometrium. All the features of anaplasia anaplasia features are present. Which are the features of anaplasia? Which are the atypical features? So that is high NC ratio, high nuclear cytoplasmic ratio, hyperchromatism means dark blue color nucleus, prominent nucleoli. You know, nucleoli within the nucleus is seen, which is an unstained portion. There will be loss of basal polarity. So, in short, there will be marked anaplasia in this category. And the key important feature is that in this category, usually papillary projections are seen. That is finger-like projection of the cell, and it will be lined by columnar cell with atypia, right? It will line by columnar cell which will show the atypical feature. These are the atypical features. So all feature of malignancy is present. Metastasis and stromal invasion are very common. This tumor can metastatize to other organs, and so the prognosis is very poor. Patient can die because of this tumor if not treated early. So this is the photomicrograph. Micrograph means histopathological appearance. So here you can see a papillary projection. Can you able to appreciate this is a finger-like projection? So finger-like projection of the cells are seen, which is lined by columnar epithelium, which is highly atypical. And P53 mutation can be seen immunohistochemistry in this right hand side. Alright. So at the nutshell, what is the difference between the type 1 and type 2 endometrial carcinoma? This can be asked in an exam, and this is the summary of our today's lecture. So at the nutshell, type 1 endometrial carcinoma is an endometrioid type, usually seen in 55 to 65 year, but type 2 endometrial, that is serous carcinoma, seen more than 65-year age. Can you able to understand why it is seen in a patient of age group more than 65? Because it arises from the endometrial atrophy, right? So more old age group patient. Which are the risk factor? Here obviously all risk factor of hyperplasia is present, increased estrogen, that is obesity, unopposed estrogen, hypertension and diabetes. While here the risk factor is endometrial atrophy, thin physiques and your old age. What is the incidence? So more than 80% tumor is type 1, but less than 20% endometrial carcinoma could be type 2, right? So incidence of endometrial type 1 is more. What is the precursor lesion? Hyperplasia, obviously, and here the precursor lesion is endometrial atrophy. What is the clinical course? This is non-aggressive tumor. Prognosis is good, but this is very aggressive tumor, type 2. Body mass index is very high because it's arise in the background of obesity, right? So body mass index is high. But here there will be thin physiques and body mass index is low. Parity is null, here also null or low. What is microscopic appearance? So this is the endometrioid type of adenocarcinoma. You can see a well differentiated to poorly differentiated glands. Glandular pattern is maintained. While here there will be serous or clear cell pattern with papillary projection. What is the molecular feature? Important one is P10 mutation. KRAS mutation, POL, P53 mutation also can be seen. While here there will be mutation in P53, PIK3C, FBXW7 or triple P2R1A. The mutations are different. Estrogen association obviously present in this category, while here there is no association with estrogen at all. Estrogen and progesterone receptor are common here, but here it is uncommon because it's not related to hormone. So hormonal sensitivity is present in this category, right? But here there is no hormonal sensitivity. Grading is usually low. This is good tumor, good prognosis. So grading is low. Usually it is well differentiated, but here the differentiation is low. It's a very high grade tumor. Alright, metastasis is more common in type 2. It is a very aggressive tumor and metastasis can be seen. It can spread to peritoneum, lymphatic spread, hematogenous spread, and it can spread in a variety of organ. Type 2. Prognosis is poor, patient can die in this category, while here the prognosis is good, and metastasis is very rare. Alright. So what would be the clinical feature and diagnosis of endometrial carcinoma? How the patient will present? So patient will present mainly with vaginal bleeding, and diagnosis is done by biopsy. First, the patient will undergo ultrasonography examination in which the growth in the endometrium is revealed. So the gynecologist will do the curettage, right? The curettage will be done There will be dilatation of the cervix, and they will scrape the inner lining of endometrium, right? They will do the curettage and they will send it, gynecologists will send it for histopathological examination. And in histopathology, if the carcinoma is present, the features of carcinoma will be seen. So it's diagnosed by histopathological examination. Alright, so endometrial carcinoma diagnosed by histopathological examination by curettage. Alright, and to grade the tumor, CT scan, MRI and PET scan can be done. Molecular testing can be done in the form of next generation sequencing for the detection of respective tumors. We have discussed that variety of mutations seen in type 1 and type 2. So they can be detected by polymerase chain reaction or by DNA sequencing technique, particularly next generation or Sanger sequencing, right? Immunohistochemistry also having the role in the diagnosis. Alright, so based on clinical feature, you will suspect the endometrial carcinoma, the gynecologist will do the curettage, histopathological examination will be done, and the cancer is diagnosed. And ultimately, there will be CT scan, MRI, and PET scan, as well as molecular testing for further management of endometrial carcinoma. So this is all about the endometrial carcinoma type 1 and type 2. These are the references for the today's lecture. So hope you have enjoyed watching this video. We will be right back with a new video. Till then, take care and bye bye. Thank you very much. Thank you for the listening. Thank you.